Okay, good afternoon, everybody. So I'm going to speak about the experience that we have had with PSLT at the institution where I work, which is Fundación Oftalmológica Nacional in Bogotá, Colombia. And I thank all the residents and my colleagues who have collaborated with our research and collecting the data on this. This is my commercial relationship. Clinical management of glaucoma has been in constant evolution with medical, laser, and surgical technologies. Trabeculoplasty, after 1970, when it was first introduced, was the favorite laser procedure for a very long time. And in 1995, the glaucoma laser trial showed it was really effective and a very safe procedure. It changed when Park and Latna showed that selective laser trabeculoplasty was as safe and showed a very good efficacy, just as AOT, working on the trabecular meshwork on 360 degrees, while with AOT we could only use 180 degrees. It is very important because one of the issues treating patients is the adherence to medical treatment. So using trabeculoplasty helps patients who are not adherent to the pharmaceutical therapy or as an adjunctive therapy for those who need something else to be done before we go on with surgical treatment. We're in the mix era, so many people ask, is there going to be a gradual decline of trabeculoplasty? Because there's an overlap of target patient population. The people who we treat with trabeculoplasty are the people where we need to lower down, but people who do not have a target intraocular pressure that has to be really in the single-digit area. So yes, we do have an overlap of target patient population, but trabeculoplasty is still a less invasive extraocular procedure. It does not need to be combined with lens extraction, and people just can go to their houses without having their eye open with an incision. I know it's a very small incision, but it is a much less invasive procedure and is much less costly compared to MIGS. So we still have space for trabeculoplasty, for laser trabeculoplasty. There have been new generations of laser trabeculoplasty. We have the pattern scanning laser trabeculoplasty, the micropulse laser trabeculoplasty, and the titanium sapphire laser trabeculoplasty. We're going to talk about that a little later. Where does pattern scanning trabecular laser trabeculoplasty come from? It was first introduced in 2006 for retinal treatment because there was the possibility to reduce and control the energy that was delivered to the tissue at the retina. For trabeculoplasty, what we have is this arc, this 22.5 degree arc that is projected as an aiming beam on the trabecular meshwork. And when you're doing the treatment, this is what you see, and that's what the laser is doing. So this arc is constantly changing. Whenever we finish the treatment, it will align again on the trabecular meshwork, but we're not going to have overlaps of the area that we have treated before. And we're going to have a constant pattern of spots with the same energy that we have titrated before. This is how we titrate. So this is the point where we titrate. We place that point over the inferior trabecular meshwork, which is much more pigmented, and we blanch that specific point. After we have blanched this specific point using laser at 10 milliseconds, we already know that that is the energy we want to deliver. But automatically, it's going to be reduced in time by 5 milliseconds. And that is what we're going to use in that pattern. So we're not going to have overlap of treatment, and we're sure that we're going to deliver the same energy, at least in that 22.5 degrees of arc. So we're producing less scarring because we have less inflammation, and we're not going to do overlapping of the treatment. It's shorter because we don't have to point, like we do with ALT or with SLT. We treat in steps that are longer, and we already know where we are treating, because this this is a PSLT graphic user interface where we know where we titrated, and it's always going to show us where we left. So if the patient moves, it will stop, and it will tell us where we left the treatment. So we're never going to have overlapping. This is the surgeon's perspective. This is how we see the pattern. It is not as clear. You can see a more clear thing when you have it on the slit lamp. And this is what the surgeon is looking. So we have to line the pattern over the trabecular meshwork. We use the paddle, and that's what happens. Of course, we have to know very, very, very well how the angle looks like, and we have to keep track of the trabecular meshwork. But as long as you see that, and then you're changing the lens, and it's going to help us not to have overlap. This is what we have been doing. We wanted to see, to compare PSLT versus SLT. And we decided to do this and to follow patients with open-angle glaucoma or ocular hypertension. And we have PSLT in our institution, and the other surgeon has SLT at his office. And we decided to compare what happened with these patients after we did trabeculoplasty. All patients had to receive treatment in 360 degrees. And we started our follow-up. The age was very similar. We had more female patients than male patients. And the stage of their glaucoma was very similar as well. We had higher intraocular pressure among the SLT patients compared to the PSLT. And I'm going to show you the results of the follow-up. This is the number of medications that patients had in both groups. We did not have reduced the medications in these patients. Patients continued with their same amount of drops. And this is how PSLT behaved, the patients with PSLT that received PSLT behaved compared to PSLT. So here you can see that intraocular pressure was higher with SLT. It was a little lower with PSLT. And patients with SLT had a more pronounced reduction of the intraocular pressure compared at the first day. Even at the first week, the SLT patients had a better reduction compared with PSLT. But in the as time passed, the reduction was very similar at the first month, just like you may look over here. It was 33% for SLT, 32%, almost 33% for PSLT. That reduction was kept at the follow-up at 6 months, And at the follow-up at 12 months, it was a little lower for the PSLT group. Of course, our group was smaller. I mean, it's a small follow-up group, and results can be influenced by this. This is another study by Dr. Mansouri. It was published in Ophthalmology 2016, at Acta Ophthalmologica 2016. And they wanted to compare safety, tolerability, and IOP lowering efficacy in groups of PSLT versus SLT in fellow eyes of untreated patients with glaucoma. For our study, patients had to have intraocular pressure over 20 and had to have medications. Here, they included patients with any kind of intraocular pressure. I mean, intraocular pressure could be below 20, and that's the difference with our study. They had 29 patients, 58 eyes with primary and secondary open-angle glaucoma, and they would go with PSLT or SLT in each eye. Patients' comfort level to treatment was assessed using a visual analog scale, and follow-up visits were at week 1, month 1, 3 months, and 6 months. Success was defined as intraocular pressure reduction over 20%. And the main outcome measures were safety, tolerability, and IOP reduction. And this is what they found. The mean age of patients was 54 years, more or less 15 years of a standard deviation. Baseline IOP was similar between both groups. It was 17 for PSLT and 16.8 for SLT, so their intraocular pressure was lower than ours. And in the PSLT group, the mean IOP at 1, 3, and 6 months was 14 millimeters of mercury and 14 millimeters of mercury in their follow-up. For the SLT group, the mean IOP at 1, 3, and 6 months was 14, 13, and 13 plus or less 3 millimeters of mercury for a deviation, a standard deviation. The IOP reduction in the PSLT group was greater compared to the SLT group in month 1 and 3, and the VAS score, the visual score for comfort, was better with PSLT eyes, 23.9, than the SLT, which was 50. In conclusion, both laser modalities had similar safety and efficacy profiles, while the PSLT was better tolerated by patients. This is another study by Turati, in which they followed patients on which they had treatment with PSLT, and at 6 months they found a 24% IOP reduction. And this is a study by Nosaki where they included 12 eyes for PSLT and 12 eyes for SLT, and they did their follow-up for 6 months, and they found that PSLT, they had a reduction of 33% compared to SLT, where they had a reduction of 21%. This is the relative IOP reduction rate, which was 33% for the PSLT group compared to 21% for the SLT group at 6 months, and there were no significant differences over time. These are the late developments in laser trabeculoplasty. It's a picture taken from Dr. Sang article, which was published at the British Journal of Ophthalmology in 2015, where they compare SLT, MLT, T, SLT, and PLT. For SLT, their mechanism is a selective destruction of pigmented trabecular meshwork cells without thermal or collateral damage. it can be done in 180 degrees or 360 degrees of trabecular meshwork that can be treated. What you see is that small bubbles come, and it can be repeatable. Common complications are in IOP spikes and anterior uveitis. For MLT, how it works is that they have thermal effects without trabecular meshwork damage in repetitive microsecond pulses, followed by intermittent rest period, so there's less thermal damage. Patients can have treatment in 180 degrees or 360 degrees of trabecular meshwork. There's no visible tissue reaction. People can repeat these MLT. There's this titanium sapphire laser trabeculoplasty, which uses near-infrared energy with deeper penetration into the juxtacanalicular meshwork and the inner wall of Schlemm's canal, so it goes deeper than the other lasers. It can be used only in 180 degrees, and mini bubble or burst of pigments is what you see when people use the titanium sapphire laser. It can theoretically be repeated. IOP spikes are possible. And what I have been talking about, which is the pattern scanning laser trabeculoplasty, which different to the other lasers, you can have 8 segments of treatment or 16 segments of treatment. There's no visible tissue reaction after energy titration. It says unknown in this article, but patients can be retreated with PSLT. And transient IOP spikes are possible just like the other treatments with laser trabeculoplasty. In summary, pattern scanning laser trabeculoplasty is an efficient method of treatment for open-angle glaucoma and ocular hypertension. It provides nearly uniform coverage of the trabecular meshwork with more than 1,000 spots of 100 microns in diameter, delivers the exposure in 16 steps using the pattern scanning system of PASCAL. There's a reduced amount of tissue damage that may provide benefits similar to SLT, MLT, and the titanium sapphire laser trabeculoplasty, but with reduced scarring and possibility of retreatment, a favorable safety profile, less post-operative inflammation, less post-laser IOP spikes. It is not useful for secondary glaucoma like uveitic or neovascular. And that's all that I wanted to tell you. Thank you very much.